Okay. The lungs are contained entirely within the thoracic cavity, and they sit on top of the diaphragm. That's just a transverse section of the lungs showing um, how the heart takes up some of that left lung area, and it shows the para or the visceral pleura and the parietal pleura, how they line and surround the lungs in the thoracic cavity. Okay, so let's talk about how we um, accomplish this breathing. So our um, one of the things to realize is that, or one of the numbers to remember is that air pressure, at sea level, standard temperature and pressure and everything, the air pressure is 760 millimeters of mercury. So that's this number right here. And also, a thing to remember is that air is going to move from an area of high pressure to an area of low pressure. So the lungs at rest are 760 millimeters of mercury, just like the outside air pressure. To make air come into the lungs, we've got to decrease the pressure in the lungs. So the way we do that is we contract this diaphragm, and when the diaphragm contracts, notice it's way up here in A, but in B, when we contract it, it's down here. That makes the volume of the thoracic cavity larger. And when the volume is larger, you have more space in there, the pressure is going to go down because volume of the container goes up, the pressure will go down. So when the pressure went down, now the pressure inside the lungs is only 758 millimeters of mercury. And the air can rush in from the outside. Um, it's not, oops, sorry, I'll go back here. It's not just the um, diaphragm going down. Remember in A&P1 we talked about those muscles, the sternocleidomastoid muscle and the pectoralis minor muscles. These muscles can help to elevate the sternum and elevate the ribs, and then the external intercostals can expand the ribs also, all creating more space in there. But the kind of big player is the diaphragm. Okay, lung capacities. It's really important to understand these um, volumes so that you can understand the capacities that come after. So a normal tidal volumes are is how much air we take in, and so breathe in, inspiration and expiration um, with a normal breath. And it's about 500 milliliters of air. Worst L ever. There you go. So it's about 500 milliliters, so half a liter. And that's when you're just sitting there, you're relaxed. Um, your inspiratory reserve volume is a maximum inhalation after a normal inhalation. So you get a normal tidal volume inhalation, and um, the inspiratory reserve volume is how much more air can you force into the lungs. Expiratory reserve volume is how much air you can breathe out after your normal exhalation. So that's how much air you're going to force out of the lungs. And there's always a residual volume in the lungs, which is how much air is in there after um, your maximum exhalation. So the residual volume is just kind of keeping the lungs inflated. So now that you understand those, you can understand the capacities. So total lung capacity is all of them. Residual volume plus inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So it's all the air in the lungs. The vital capacity, think about vital, living, is how much air you can actually move. So that's your total lung capacity minus what has to stay in there, your residual volume. Functional residual capacity is your residual volume plus your expiratory reserve volume. Inspiratory capacity is your tidal volume plus your inspiratory reserve volume. So that's the maximum air that you can be inhaled after you have a normal tidal volume exhalation. So this chart is a good kind of visual representation of what we just talked about. So here's this tidal volume, right around 500 milliliters. And then you've got this inspiratory reserve volume, which is from here to here. It's how much more air you can force into the lungs. Expiratory reserve volume is normal tidal volume exhalation, how much more air you can force out. And then residual volume is what stays in there. Okay, minute ventilation is the amount of air that is moved into the respiratory passageways. So it's your tidal volume multiplied by your breathing rate, so breaths per minute. So if you have your tidal volume is 500 milliliters and you do, say, 15 breaths per minute, then your minute ventilation is 7.5 liters per minute. Alveolar ventilation rate is your tidal volume minus your dead space. So this is how much air actually gets to the alveoli. Well, and then multiplied by your breathing rate. Non-respiratory air movements, you can see them all here, but these are things that are not meant to help us breathe, but our respiratory system is called into action to do these. So this is an expiration. Expiration happens, one, because the elastic recoil of the lung tissues. The lung tissues fill up with oxygen, but they don't like to be in that state, so they're going to force that air out. Also, those abdominal organs are going to push back up against the diaphragm. You get maximum expiration when you contract your abdominal muscle walls. And just try this. I mean, sitting there, just try to breathe out as much air as you possibly can and see how, and try to sit upright. You can't because you're contracting those stomach muscles. Also, you contract those posterior intercostal muscles. Okay, respiratory centers. We've talked a lot about the respiratory centers, or we've introduced those in chapters 11 and 12. But those respiratory centers in the ventral respiratory group and dorsal respiratory group in the medulla. In general, both the dorsal respiratory group and the ventral respiratory group function in both of these, rhythm of breathing and forceful breathing. So it's not just that ventral respiratory group only does forceful breathing. They're actually both involved in those, and that's some not so recent research, but there's a lot of evidence to show that they're both involved with both. Factors affecting breathing. Well, you've got all right, decreased blood oxygen concentration doesn't have as big of an effect as you would think. But remember, in the carotid bodies and the aortic bodies, there's those chemoreceptors, and those do register if there's decreased blood oxygen. But think about the oxygen that's going to be, or the blood that's in those aortic bodies and carotid bodies. They're going to be highly oxygenated because that blood just got back from the lungs. So it would take a lot for this to have really low oxygen. high blood CO2 and high cerebrospinal fluid hydrogen ion concentration is a greater stimulus for breathing, in that they stimulate chemoreceptors in the respiratory centers in the brain to cause that alveolar ventilation to increase. So, what else? In A&P1, we did talk about the contraction of the motor impulses and the contraction of the diaphragm. But when these centers register high levels of CO2, they're going to cause the diaphragm to contract, and so we can breathe more. There's also stretch receptors within the lung, and those stretch receptors are, so right here, the stretch receptors are there to prevent the lungs from overinflating. So the stretch receptors will send a message to the respiratory centers to tell it to stop expanding the lungs. Alveolar pores is how air passes from one alveolus to another. So even within one alveolar sac, there's small spaces for air to pass through from each alveolus, and that will help distribute the air throughout the alveolar sac. Respiratory membrane we already talked about, but here's that alveolus with its simple squamous, and then you've got the capillary lumen. The thing we haven't talked about was surfactant, which helps to decrease the friction along the surface of those alveoli. Okay. Diffusion through the respiratory membrane. We've already hit on this, but these numbers are pretty good to talk about. So within the alveolus, you have a carbon dioxide partial pressure of 40 millimeters of mercury and 104 millimeters of mercury of oxygen. Now the blood coming back from the body tissue has been used up as far as the oxygen, and a lot of carbon dioxide has been dumped into it. So carbon dioxide here is in a high concentration. So it's going to move from the capillary into the lungs, because it's going to go from high 45 towards a low of 40. Oxygen's 104 in the lungs and only 40 in the capillary, in the blood in the capillary. So the oxygen is going to diffuse into the capillary until the pressures are equalized. So, but notice that even the blood coming back from the body still has some oxygen in it. Oxygen is transported through the blood. Most of it is in the form of oxyhemoglobin. So most of it's bound to hemoglobin. Some of it is just traveling within the blood. All right. The purpose of these graphs is to talk about when and where oxygen is released. So y-axis is percent saturation of hemoglobin, x-axis is the partial pressure of oxygen. And oxygen dissociates from hemoglobin in places where there's a lot more carbon dioxide. And so this makes sense, because if you say you're riding a bicycle and you're riding as hard as you can using your leg muscles, well, you're going to be producing a lot of carbon dioxide in those leg muscles. And you would want to deliver more oxygen to this area. Also, you might be producing lots of lactic acid, and so when pH gets low, you dissociate more oxygen. More oxygen leaves hemoglobin. And the same would come true, or would be true, and you could make a graph like this for heat. So if you didn't keep the body temperature, you wanted to make these graphs warmer body temperature or colder than body temperature, you would see more oxygen is released when it gets to a warmer temperature. Okay, carbon dioxide transport in the blood. Some of it's dissolved within the plasma, some of it's combined with hemoglobin, and some of it's in the form of bicarbonate ions. The bicarbonate ions, though, cause this chloride shift because bicarbonate ions diffuse out of the red blood cells, but they're a negatively charged thing, so the chloride has to shift back in. So chloride from the plasma shifts back into the red blood cells, and that maintains that electrical balance. When we get to the lungs, though, that carbon dioxide that's diffused in the plasma can just go into the lungs. And then the bicarbonate ions have to go back into the red blood cells and so that the bicarbonate ions can be changed back over to carbon dioxide and water. And then the carbon dioxide can then move into the lungs. Okay, lung diseases, you got restrictive diseases, which makes it hard to get air into the lungs. So something's blocking, say, the bronchioles. These could be a muscular issue, like maybe you're paralyzed and your diaphragm doesn't work, or cancers with tumors blocking it. Obstructive lung diseases makes it hard to get air out of the lungs. So emphysema, asthma, COPD, they make it hard to get air out of the lungs. Now, if you can't get air out of the lungs, you can't get air into the lungs. But the root cause of obstructive are you can't get air out of the lungs. Lifespan changes, once again, nothing but good news as we get older. Less cilia, mucus thickens, nothing but good stuff. So just read through that and look forward to your future. Clinical applications. So science has recently discovered that cigarette smoking is bad for you, which is, been confirmed. But the cilia is the first thing that happens. You just burn your cilia right off when you take that first puff of your cigarette. And then you produce excess mucus because there's no cilia. And the excess mucus is responsible not only to the chemicals and the burning of the lungs, but also cilia is not there to move it around. So you know how you've got that smoker maybe in your life, and they wake up in the morning, the first thing they do is hack for a half an hour and have that smoker's cough. It's because they don't have that cilia beating that mucus into their pharynx all night, so it's just been stuck there. Lung cancer is more common in people who smoke. Emphysema. So you get a lot of damage from smoking, and that damage can be reversed and start to be repaired as soon as you stop smoking. So if you smoke, stop smoking. It's going to kill you. Okay, that's it.